All right. Good morning, everyone.
Right.
Julie. I am here with Julie Brill. She is a IBCLC, and I've known Julie for quite a while now. And she is a long-term birth doula, but mainly is teaching birth doulas, teaching childbirth educators, and she is also an IBCLC. So she works with lactation consulting and women who are breastfeeding. Hi, Julie.
Hi. How are you, Angie?
Hey, thank you so much for doing this with me this morning. We have a lot of questions prepared, and I feel like hopefully we'll be able to keep it short, even though each of these questions we could write a book on probably. But I do think it's really important for us to just go through them and get the basics out because they're really solid, I think they'll be full of really solid information for women who are pregnant and just getting on board with breastfeeding and preparing to breastfeed. So let's see. So one of the things I said is that you are offering private breastfeeding education classes for women who are currently pregnant and hoping to breastfeed once the baby arrives. So talk to us a little bit about why it's important to prepare for breastfeeding and like what are the benefits of that?
Sure. I think a lot of people expect that breastfeeding is just going to happen. So there's a lot of emphasis on childbirth education and getting ready for that day the baby's going to come out, and often much less focus on postpartum in general, and especially on breastfeeding. People think that part will just like take care of itself. And it's actually a lot more learned behavior than people expect. So if you haven't surrounded yourself with breastfeeding newborns your whole life, which most people haven't, then you need to take steps in pregnancy to make that process easier once the baby is here.
And what does it look like? It's a one-on-one sit down with you, and you're going through just kind of like the basics of breastfeeding.
Exactly. So we usually do it in about 90 minutes. Partners are welcome, and we just talk about the basics of latch and positioning, how to know the baby's getting enough, how often to feed, what are the signs that the baby's hungry, what are the signs that they're full, how to know when there's a problem, how to get breastfeeding off to a good start. Just sort of the basics that people often aren't thinking about if they've never had a baby.
Yeah, absolutely. I think sometimes women feel like it's just a no-brainer. Like when the baby comes, the baby will breastfeed, and it'll be all kind of automatic. And I'm sure that some of that is automatic, but there's just so much to know. At least this is how I felt um, that I didn't know I didn't know. Do you know what I mean?
Right,
Like there's
right.
so much out there, so much information, so many nuances, and like we said before we started recording, it's a changing game. So what was going on at 2 weeks might be totally different than what's going on at 4 weeks or 2 months or what have you. And so there's so
Definitely.
much information to learn. I think getting that head start in the beginning can make all the difference.
When people have done that, they're so grateful later. There's still a lot to learn, but it's you have a foundation that you're building on.
Yeah, that foundation I think it makes all the difference. Excellent. So I think the other thing we were talking about this briefly, just to get people set up for success as much as humanly possible before the baby is born. One thing I wanted to ask you about today is how some common medical interventions can impact breastfeeding. And I know there's a long list of what those medical interventions could be, but even just for example, something as what feels like benign as IV fluids or induction methods or even pain medications really can have impact on breastfeeding in the days and weeks following the birth, right?
Yes, definitely. And I think often people have those interventions in the hospital without really understanding how it's going to impact breastfeeding. So IVs are a great example. A lot of people in the hospital have IV fluid. And when the mom gets overhydrated with IV fluid, the baby is overhydrated as well. So their birth weight, even though the mom pushed them out at that weight, is really not their birth weight. So we would expect much more rapid weight loss in the first 24 hours because they're trying to get down to their normal fluid levels. And so in that case, you really want to be looking at the 24-hour weight, not the birth weight, as the starting weight. And then looking at not losing more than 7 to 10% of that 24-hour weight, because the first day is really just fluid. And a lot of people don't know that and get alarmed and start supplementing when maybe they don't need to. And the other piece of that is that the extra fluid for the mom goes into her extremities. So ankles, commonly hands, but the breasts are an extremity. So a lot of times when her mature milk comes in day 2, day 3, and she's full of milk, she's also got a lot of IV fluid interstitially in the fluid, in the tissue.
Wow.
And people often pump at that point and actually bring the IV fluid forward and make it harder. That fluid has to go back. Yeah, so it can be definitely more challenging, a bigger hill to climb initially. Sometimes it looks like the baby's trying to latch onto a chocolate chip glued to a balloon. There's just like, the breast is so engorged, and a lot of it is that IV fluid.
Wow. And I can
Yeah.
imagine that I mean, I know this isn't true for all women, but when my milk came in, I was super engorged. And I can't imagine having something on top of that
Exactly.
issue, not
Right.
only from a discomfort standpoint for me, but also from, like you were just describing, like a difficulty having the baby latch on perspective.
Right. And that was without an IV. And then if people have an IV and Pitocin, the Pitocin is an antidiuretic, so it's even harder to get rid of that fluid. If
Wow.
they've had an IV with an epidural, then often they're really well hydrated, overhydrated, because the nurse is trying to keep their blood pressure up with the IV fluid. So they're intentionally giving them a lot of fluid, which has to go somewhere afterwards.
Right. And I imagine that there's a lot of pressure, especially when you're looking at the baby's birth weight issue, that when the weight drops significantly from the moment that the baby is born,
Right.
the level of alarm goes up, the level of confusion around baby's weight, and then the pressure around potentially needing to supplement, not letting things kind of even out in the few days after the baby's born kind of gets ramped up a little bit because those numbers are confused because of all of these fluids.
That's exactly right. So you need to look at how many wet diapers the baby is having in the first 24 hours. So normally we might see 2 Ps, maybe 3 in that first 24 hours. And if you're seeing 4 or 5 or more, that's the IV fluid. That's just showing you need to go off the 24-hour wait.
Wow. And do you feel like that's pretty commonly known in regards to like nursing and doctor and OB staff in the hospital? Is that
I
something?
don't think so. I mean, a lot of times the hospitals aren't taking a 24-hour wait. People really need to ask for that specifically. It is an American Academy of Pediatrics recommendation to go off the 24-hour wait when there is an IV, but a lot of the pediatricians don't seem to be keyed into that.
Yeah. Yeah, this is why I want to have these kind of discussions, because my goal across the board in my patient care is to, I know this is so true for you as well. I think that's why you and I connect so well on a professional level, and otherwise, but is that we are all about educating patients so that they can be their own self-advocates, so that they can take care of themselves, take care of their babies, but also decrease the level of alarm and fear that is
Right.
sometimes stirred up in the medical community. So just having knowledge of that this is a potential issue and being able to go into a hospital birth armed with that information and maybe say, like, either is there a chance we could not do IV fluids? If that's not possible, or even if the mom doesn't want that, is okay with the fluids, at least having the knowledge that these things could disrupt breastfeeding. Wow, that really helps take so much fear, confusion, pressure, alarm from, the days following, which are already
Stressful.
stressful
Yeah.
and just a lot. The
Yeah.
learning curve from the moment a baby comes out is humongous, I think. So
Yeah.
yeah,
Definitely.
yeah, wow. And do you find that in hospitals, are we able to ask to not have, can we say, I'd rather not have IV fluids? And is that something that, do they grant the wishes of birthing moms who are saying those sorts of things?
Sure. I think it depends a lot which hospital. It seems like some of the hospitals routinely do IVs and some don't.
Yeah.
But anybody who's being induced is going to have an IV. Anybody with an epidural is going to have an IV cesarean birth. So it winds up being, significant a significant number of moms and babies are having them.
Yeah. Yeah. Okay. Well, we can still be armed with the information, right?
I agree.
And make those choices ourselves and work with our doctors around it.
Definitely.
All right. I could go on and on forever just on this topic, but I do want to talk about a very related issue, which is in the hours after birth, what can we do to kind of best support our breastfeeding efforts? Because there are so many things that are happening at that time. How can we really set ourselves up for success?
Yeah.
I know there are so many variables here, but maybe just talk about some of the basic things and then we can get into some of the more detailed.
Yeah. So I love that question. I mean, first of all, it's just keeping moms and babies together, skin to skin. And the babies don't have to breastfeed right away, but if they're skin to skin with the mom, she's helping to regulate their body temperature and their heart rate. And then they're in a prime position to get around to breastfeeding in the first, hour or so. That's excellent. The American Academy of Pediatrics, they say no non-emergency procedures until the baby has breastfed. So their own recommendation is, they don't need antibiotics, they don't need a vitamin K shot, they don't need to be weighed, they don't need anything, they just need to be skin to skin. Again, it really depends on the hospital and the particular nurse that you wind up with in L&D that day. But certainly if people are doing a birth plan, they can put that on their birth plan. And then, if they do delayed cord clamping, that just keeps the baby with them longer. And then having the baby skin to skin. And they're doing that even more now with cesareans. So family-centered cesareans where the mom is getting the baby during the surgery. Some people are nursing in the operating room. So, it's possible in all kinds of situations that maybe we never would have guessed would be possible in.
Yeah, I'm so grateful that the hospitals in this area are open to that right now. It seems like at least some prominent hospitals really are supportive of that. And it seems like at least that's the trend we're moving in.
Definitely. Yeah. I mean, I think in the Boston area, family-centered cesareans really started at the Brigham.
Yeah.
And they, that's a huge Harvard teaching hospital, and it's kind of spread from there.
Yeah.
So I think all the area hospitals are doing some variation of family-centered cesareans now, and it makes a big difference.
So skin to skin is the biggest thing.
Yep.
And then does that mean also if you have a cesarean section and you're doing skin to skin and kind of breastfeeding within the first hour, are your arms free?
So part of the way they do the family-centered cesarean is one arm is free. Okay. So they have the pulse oximeter, the blood pressure, everything is on one arm, and the other arm, hopefully the dominant arm, is free. And then, people need assistance. They're flat on their back.
Yeah.
And there's a nurse that's just their job to be helping with that.
Yeah.
And of course, it depends what's happening with the baby. I mean, sometimes babies need to go to the NICU. So it's all dependent on the circumstances, but it is definitely happening and happening more and more.
Yeah. I'm so thrilled that that's even something that we are able to consider.
Right.
Really, I encourage women so much, and this is why I send people to your class all the time, because this is the type of thing that we can learn about ahead of time as options so that we know, either if you have a planned cesarean for whatever reason, or you have an emergency cesarean, just having 5 minutes worth of information about how to kind of protect. I don't know if that's the right word, but that's what's coming to mind.
Yeah.
Yourself and your baby around like breastfeeding and skin to skin early on and that sort of thing is huge, because we can advocate for ourselves and ask for what we need around those things, like having an arm free and moving towards family-centered characteristics of a cesarean birth.
Right. And the partners too can be a huge help with that. If they've heard the information prenatally and they're able to reiterate it and ask for what they know they've discussed prenatally.
Right. Really amazing.
Cool.
All right. So I think the other thing that I want to talk about is giving people an idea of why they might need to reach out for help and what things, like specifically an IBCLC, could help for. So before you answer that question, actually, will you give us just an idea of what an IBCLC is and then how IBCLCs differ from maybe a lactation consultant, or I think you were saying, before we press record, that even in the hospital you might not get an actual lactation consultant. So can you just talk to us about, like, when you have a hospital birth, like, who's around who might be consulting on the breastfeeding piece, and then what are the differences between those folks who are offering advice?
Yeah, so there's a whole alphabet soup out there. The IBCLC started in the 80s. I was actually came out of the Leche League, which was mother-to-mother support. And the Leche League felt like there should be professional lactation consultants. So they helped to establish IBCLC. So that stands for International Board Certified Lactation Consultants. And to become an IBCLC, I did 14 college courses, 1,000 hours of breastfeeding support, 90 hours of breastfeeding education, and then I did the international board exam. But they didn't, when they did that, trademark LC or lactation consultant. So IBCLC means a specific thing. Lactation consultant or lactation nurse means anything. And a lot of the nurses in the hospital are CLCs, which are certified lactation counselors. So they do a 45-hour course and they take an exam on Friday afternoon. So it's a very different preparation track, and a lot of times people don't know who they're working with.
Yeah.
And so it's confusing.
How do you know? In the moment
you have to ask. Unless you ask, you really don't know.
Okay.
There are IBCLCs who are working in the hospital as well, and most hospitals have them some of the time. So they might not be there at night, but usually in a 24-hour period, you can ask to see an IBCLC.
Okay.
And that is sometimes helpful if for no other reason than they draw up a written plan usually, and then everyone is following the same plan. One of the things that's really hard about lactation for families often is it's more art than science. So you're not necessarily getting consistent information. But if the family meets with an IBCLC, she draws up a plan, then at least everybody's literally on the same page, and they know where to go. And then there are private practice IBCLCs who do home visits. And that's an opportunity to get much more help than you would probably get in the hospital. Those visits are typically like 2 or 2.5 hours. So people can really go through their history, get all their questions answered, get a written care plan, have a breastfeeding session assessed. We will often do weighted feeds so you can see how much the baby transfers and really get a better picture of what's going on.
In that situation, you're not in the environment of the hospital where there are nurses coming in and out. Maybe you have visitors. You're just in those first few moments of adjusting. And I think having that home visit, it opens up a whole world of being able to really engage in the process, ask questions, figure out what you've had difficulty with and really get pinpointed answers on it. Whereas the hospital, even though I think it can be a great help, like, gosh, there must be so many other things going on at the same time that you're trying to figure out how to breastfeed.
Right. And breastfeeding is different at that point. Usually it's the colostrum and not the mature milk, and the babies are often just sort of starting to wake up and be present. So it's changing, hourly, daily in those first few days.
Yeah. What a gift to have someone really come into the home, though, one-on-one attention, you quietly with the baby, figuring it out.
I agree. And a lot of people actually have full reimbursement from their insurance companies. So it really is like a no-brainer. The Affordable Care Act, part of what they did was they made provisions for lactation. So people should have coverage. As I feel like if I could get a free personal trainer to come to my house and help me, or, why wouldn't you do it?
Yeah, especially with something as important and sometimes as challenging as breastfeeding.
Right.
Yeah, wow, that's so amazing. I wish that more people knew that it was available and took advantage of reaching out. So what are, once you get home from the hospital, you're past the first kind of 3 days of breastfeeding, what are some of the reasons that you would reach out to IBCLC?
Well, pain is probably the number one reason, and that's actually the number one reason people wean before they want to. I always feel like pain is an emergency if somebody calls me and tells me they're having pain, because they're at risk for weaning.
Yeah.
And, they're at risk for it getting worse instead of better.
Right.
So that for sure is a red flag. I think some people expect that breastfeeding is going to hurt, but, that's a red flag that something is wrong.
So
Um,
if you're in those first, the first week or two of breastfeeding and you are experiencing pain, is that an automatic reason to call somebody?
I think so. I mean, sometimes if you haven't breastfed a baby before, you might have adhesions. That moment when the baby is latching, you might think in the first week or two, I can't wait for this to be over. But it
Yeah.
shouldn't be like labor. It shouldn't be toe curling.
Yeah.
It shouldn't last through the feeding, and it shouldn't be painful between feedings. Those are all signs that something is going on.
Okay.
So that's a big red flag. Anybody who's concerned about their milk production, or that the baby's not getting enough to eat, or isn't gaining well, or comes home from the hospital and is supplementing and doesn't want to be, or is pumping, those are all red flags as well. Anybody on a nipple shield, which is really meant to be a bridge, that shouldn't be a long-term thing. Anybody who, feels like they're doing something that's really hard and could use some support, who has questions, who, wants to climb over that initial hill faster and get to the part where it's easier.
Yep.
Um, that's what we do.
I wouldn't have made it through without help. I just wouldn't have made it through. It was amazing and wonderful, but for me, it was too hard. There were too many kind of, I don't know, complications is the right word or not, but things that I didn't know how to handle, that's for sure, that I really needed help with. And I'm just so grateful to you for your help, because it made all the difference for me. And here we are, a year in, still breastfeeding, and so worth it for me and my family to be able to have, I don't know, to have kept on with it and to have gotten that help and support just made all the difference in the world. For me, it was like make or break, really. It was like you said, like women who are at risk for stopping because of the pain levels. Like, I can understand why, for sure.
Right, right. I mean, you're talking about something that you're doing 10, 12 times a day or more. I mean, if it's painful all the time,
Yeah.
you need help fast. I mean, a lot of times I think people might be able to sit at home by themselves, like they're on a desert island, and reinvent the wheel. But that's not how breastfeeding is supposed to be. You're supposed to get help, from your community, from people who have done it, from people who know how to climb that hill, who have been to the top before.
Yeah. Yeah. Amazing. Plus, during that time, as new moms, we're mothers, and we're exhausted, and there are
Yeah.
new learning curves. It's not just breastfeeding; it's the whole every piece of having a baby all of a sudden. Plus, you're managing visitors and dealing with very little sleep, and I think adding something like challenges of breastfeeding on top of all of those other things, emotionally, it's just exhausting. Physically, it's exhausting.
Right.
Really hard.
Yeah, I mean, you think about the recovery, even if birth was, pretty straightforward, you're still healing a dinner-sized plate,
Yeah.
in your uterus where the placenta was. You're still recovering from pregnancy and the labor and the lack of sleep. There's just a lot going on.
Right. Or major surgery.
Yeah, right.
So, all right. Well, this is the age-old question for lactation consultants that I hope everybody knows the answer to, but I feel like I need to ask it anyway. Is when should we ask for help?
Right. I mean, so sooner is definitely better,
Sooner
I've
is
had calls where people like have texted me in the middle of the night. I call them back in the morning and they're like, "Well, it's better. Should I still come?" And I'm like, "We can do a consult if you want." And it's still helpful, even after you've come off that crisis moment.
Yep.
Because there are so many tips and tricks that can make it easier.
Yep. I think the main message is like if you feel like you need help, call as soon as you feel like that. Like,
Right.
wait it out, because there's no benefit to waiting, and there are so many things that can be dealt with the sooner we ask for help.
Definitely. I have a consult this afternoon. I knew the family prenatal aide did a class with me. She texted me in the hospital. We set it up for today. They went home yesterday. It's like just having that continuity of help, because on day 2, you don't really know what day 4 is going to be.
Exactly. Yeah. And that's the other reason I tell a lot of women to go to your breastfeeding class in advance, is that I want them to have somebody's number on speed dial.
Right.
I want them to already have a relationship with an IBCLC in case they need it. And then that way they've already met you, they already feel comfortable with you, they already have a basic information making that call feels to me exponentially easier when you already have something kind of set up and a relationship developed to some extent beforehand. Because otherwise, you are a new mother, you're exhausted, not sleeping, you have a ton of visitors around, you have a new baby to care for, you're having challenges with breastfeeding, and now you have to research an IBCLC.
Right.
But who has time for that?
Right. And it is an intimate thing. I mean, we go into people's homes, we see their breasts, we talk to them about their mothering, we hold their baby. I mean, it is very, very personal.
Definitely. At a time where you're just, you don't have energy or resources to like pick up the house or, offer somebody tea or whatever it may be. And so it's very vulnerable. I agree. It's super personal time. So having that relationship set up in advance is a huge gift, I think.
I agree. I tell people extra points if your house looks like a baby lives there and you're in your pajamas, like we're expecting to see people who are in survival mode.
Yeah, totally. And then we didn't discuss this question, but just about milk supply and the urgency to call. I think one of the things that I hear come up in women is that they were really concerned about milk supply. Maybe milk supply was a genuine issue, and they really waited on the call. And so I think that's another point that I really want to emphasize in regards to when do you call or when do you reach out for help is, especially in times where you feel like there may be a milk supply issue and or there is a milk supply issue, like the sooner the better to reach out. Do you feel that way?
Definitely. I mean, there is an urgency to that because there's a small window when milk production is really being influenced.
Yeah.
So the sooner the better. And looking at the root cause, is it because of, something going on with the mom? Is it because of something that's going on with the baby? Is it because of interventions in the hospital? Is it because there's a problem with the latch? Like looking at what's going on and seeing how we can address it. Yeah.
It's huge. That issue alone, I feel like we'll schedule another call to talk about milk supply.
We could go down that rabbit hole all day.
Totally. And it's scary, I think, as a new mom, that feeling of potentially not being able to provide enough milk for a newborn is terrifying.
Right. I mean, we're just so programmed to feed the baby. It's like if I come to a home and the baby's not feeding well, I try just not to use too many words because nobody is listening anyway. We just need to get the baby fed. That is the most important thing.
Absolutely. All right. Well, I am so grateful for you as a resource, especially for all my patients, but certainly for me personally when I have a 1-year-old and
can't believe that.
Can't believe it either.
It's so fun to do this and see you on the other side. When we did the first interview, you hadn't had a baby yet, and here you are a year into motherhood. So awesome.
So amazing. But I was so grateful to have you as a resource personally, but also for you, for me to be able to recommend to all my patients. And where can patients reach out to you? How can they find you?
Sure. So the World Wide Web. I'm at wellbreastfeeding.com, and for breastfeeding support, wellpregnancy.com for childbirth and breastfeeding classes.
Amazing. And what geographic location are you serving most?
So I'm in Bedford, Mass, and I claim to do a half an hour radius from Bedford. It seems like more. Half an hour, 45 minutes-ish.
Yeah. That's great. That covers a lot of
yeah, I can get into Boston. I can go up and down 495, up Route 3, out Route 2. So
great. Amazing. Yeah. I'll post all of the links to your websites and everything on the link below the video so that people can reach you really easily. But I thank you so much again for coming on today and for answering all of my questions. And we'll do it again so that we can dive deeper into some of those issues, especially milk supply. And you and I can talk about this stuff forever. So
awesome. Thanks, Angie. This was fun.
Thank you so much, Julie. Talk to you soon.
Bye.